Hi, welcome in everybody. Thank you for joining us here at this Medscape live presentation at Sleep 2025. How's everybody feeling? Have a good day? Nice day? Good. We're going to go ahead and get started and bring you up to date on a few things. My name is Ed Berliner. Thank you very much for joining us here this evening. Want to remind you too that we are going to take part in something called Faculty Feud this evening. A chance to go ahead in little competition between everybody. But we do want to remind you up front that this is very interactive. Let's introduce you to the program here this evening. This is the Feud Challenge in Narcolepsy, the winning formula for personalizing treatment and prioritizing safety. What I'd like to do right now is introduce you to our faculty. First of all, let me introduce our moderator. He is the professor of neurology at the Albert Einstein College of Medicine, director of Sleep-Wake Disorders Center at the Montefiore Medical Center in the Bronx. It's good to know another New Yorker's here. All right, I'm glad. Very nice. Please welcome Dr. Michael Thorpe, if you will. Also the associate professor at the Department of Psychiatry, Medical. Let's go ahead and get started now, if you will, because our first topic is cardiovascular considerations in narcolepsy, an underappreciated safety consideration. If you would please again welcome Dr. Asim Roy. Doctor?
Thank you. Thank you for having me. All right. So we're going to highlight a little bit about narcolepsy first, and then dive into probably one of the main studies that we're going to talk about today is the BOND study and some of the data surrounding that. But as just to get everyone on the same page, I think we all understand that narcolepsy type 1 has the classic pentad of symptoms. Obviously, excessive daytime sleepiness is present in 100% of patients. And cataplexy is also present in this patient. That's obviously how we define type 1 narcolepsy. The example here is a patient completely collapsing. That's not always the typical presentation. We know that there can be more often partial cataplexy, which can be very subtle and sometimes challenging to identify in many of these patients. And then the other symptoms that we often focus on, disturbed nighttime sleep or disrupted nighttime sleep, which some patients subjectively complain about, but we also see on polysomnography great evidence and data around how much fragmentation these patients have. And then some REM-related parasomnias like hypnagogic hallucinations or sleep paralysis. And as these two can be present in normal individuals or other sleep disorders as well, so they're not defining characteristics for narcolepsy. If we go to type 2, really the only difference here is cataplexy is absent. So when we talk about prevalence, the current estimates are still reported to be around 1 in 2,000 patients. We know that it's more common than what we previously used to learn when I was in medical school. It is a chronic neurologic disorder. It's lifelong. And again, the features, as we talked about, are excessive daytime sleepiness, disturbed nighttime sleep, and then REM dysregulation. One of the REM dysregulations that's not listed here is REM behavior disorder, can also be seen in this patient population. And then obviously short sleep latencies and short time to enter into REM. The areas that a lot of these patients complain about, especially during the day, is memory-related, attention, focus, executive functioning, being able to process information, and mood as well. Here's Dr. Mignot's work in terms of looking at orexin levels. And it's not routine procedure for us to do CSF analysis across all our patients, unlike some of our European colleagues, which have a central database like this. But when we look at CSF analysis, there's clear evidence now that type 1 narcolepsy patients have significantly decreased amount of orexin. Their orexin neurons are damaged and no longer produce the orexin molecule, typically below 110 picograms per milliliter. The orexin neurons, as you all know, are the backbone of the sleep-wake system and maintain that sleep-wake stability. And once those neurons are damaged and the orexin levels decrease, we see this kind of flip-flop switch or imbalance between sleep and wake, this instability that occurs, also with instability with REM as well. This is probably where we're starting to focus a little more attention to, is something that, again, even during fellowship, I didn't really understand or was really educated on, was around the idea that independent of any other issue, patients with narcolepsy are at a higher mortality and morbidity. These are multiple retrospective studies and looking at claims database, so it can be a little murky, but it's estimated somewhere around 1.5-fold increase in mortality in narcolepsy individuals compared to the general population. Again, something to think about, something to be considerate about is this idea that these patients have a higher risk of mortality associated with the disease. When we look at comorbidity prevalence, again, this is claims data. It can get a little challenging to discern how accurate this is. As you all know, CPT and coding can be challenging, but you can see across pretty much majority of these diseases, the yellow line represents the narcolepsy patients, the green or grayish line represents normals, control match group, and you can see majority of these disease states, narcolepsy is more prevalent, these comorbid conditions across all these different comorbidities. One of the things that was interesting to me was the complications during pregnancy and childbirth were relatively equivalent in both populations. When we subgroup into the cardiovascular system, you can see based on this study that hypertension, benign hypertension, coronary artery disease, congestive heart disease, all slightly higher in narcolepsy individuals than in controlled normals. There is a slightly higher increase in NT1 patients versus NT2 as well. And then if you look at sleep disorders, sleep apnea is significantly higher than the general population here. In this study, restless leg syndrome more common, PLMs, and REM behavior disorder, again, typically that's going to be seen later in elderly individuals if they're related to RBD and synucleinopathies or other secondary causes. Headaches, very common in narcolepsy individuals. As we also know, when we treat these patient population, headaches are a common side effect of some of the therapies we use. Mood disorders are very common and often are diagnosed prior to the disease, diabetes and anxiety as well. Again, just looking at odds ratios across different cardiovascular diseases and neurologic stroke, 2.5 times odds ratio, MI 1.6, coronary revascularization 1.7, heart failure 2.6, and cardiac arrest 1.6. So significant increases based on this BOND study. We also know the therapies that we use can potentially put them at risk as well. And we know blood pressure can be impacted, heart rate can be impacted, arrhythmias, and then QT prolongation. The other area that we know impacts cardiovascular risk is the non-dipper, the impact on blood pressure, either not dipping or even going higher through the night. And we know this is linked to cardiovascular morbidity. We also know there are salt-sensitive hypertensive patients, and those patients typically increased sodium risk is going to be potentially impacting their cardiovascular risk. So for us, it is important to counsel our patients on overall cardiovascular health and do the counseling that's necessary in terms of optimizing their therapy. In this study, we're looking at that non-dipping phenomenon and 24-hour blood pressure and overall elevated in 33% of patients that were untreated in NT1 versus 5% in the control group. And again, NT1 typically saw the non-dipping component occurred with more time spent in REM sleep. As we know, there's significant sympathetic activity during REM, and this may be a contributing factor on this as well. Other metabolic considerations, we know obesity, there's obviously at the time of onset with narcolepsy, we see weight gain as well. And obesity is tied to obviously other cardiometabolic abnormalities, including obstructive sleep apnea. Precocious puberty tends to occur more commonly as well, and then insulin resistance or diabetes. Again, a couple studies published here with Cohen and Black and Genham study. You can see the odds ratio increased across obesity and diabetes in these studies. Again, odds ratio of obesity, over 2 times odds ratio. In the Ohio study, hypertension was at 1.3. Black study and Genum's diabetes was over 1.8 to 2.4. And then hyperlipidemia or hypercholesterolemia, 1.5 times odds ratio. So across multiple cardiometabolic factors, increased risk to narcolepsy patients. And so what are some of the theories around why this phenomenon can occur? We believe it's tied to obviously disturbed nocturnal sleep and daytime sleepiness. With this autonomic dysfunction, it can lead to this neural effect, which then leads to this cardiovascular, either blood pressure impact, non-dipping impact, increased heart rate, endothelial dysfunction, and then the medications that we use may be amplifying this phenomenon as well. This leads to an increased risk of cardiovascular disease, MI, stroke, heart failure, and again, downstream effects on diabetes, obesity, inflammation. And then again, other risk factors such as psychiatric, smoking, and then obstructive sleep apnea. Again, in terms of patients monitoring risk without cardiovascular disease or cardiometabolic disease, again, I think checking the weight, the blood pressure, assessing for sleep apnea, that should be automatic or routine in this patient population. And then in terms of A1C or lipid profile, again, I'm not typically doing that, but it is recommended to undergo screening at certain age groups based on gender. And then obviously if there's a family history, I think that increases the risk as well. So these are all things to consider. Again, someone with hypertension or family history of early cardiovascular disease, diabetes, or glucose tolerance issues initiate a little more frequent monitoring, annual visits to their primary care. A lot of our patients, sometimes, especially if they're young, don't always have a primary care. Recommend them to at least initiate that evaluation so they have someone monitoring some of these comorbidities. One of the things that I think was huge with the American Heart Association, they added sleep to one of the life essentials. I think finally sleep's kind of getting the attention it needs. I think wearables have also helped that push as well. One of the #1 issues in the country and probably across the world is poor sleep, insufficient sleep, habitual issues. Our access to our technology is a problem. And we know that as an independent risk factor alone is a risk for cardiovascular disease. In terms of sleep architecture impact, we know that this is a great paper on the stages of sleep between normals and patients with narcolepsy by Roth's group. This was published in terms of stage 1 and less stage 2, more stage 1, less stage 2, and then we also see decreased stage 3. And obviously with REM sleep, it's fragmented, it's happening frequently and early, and much more poorer quality, much frequent arousals as well. In terms of disrupted nighttime sleep and sleep architecture in patients, this was published by the Reston study, which is the once nightly sodium oxybate study, which looked at sleep architecture compared to placebo, and you can see the impact on frequent awakenings was significantly reduced when you go out over 13 weeks as the dose was titrated up to 9 grams. Clinically significant improvement in terms of awakening, reduction in awakenings. And again, in the Duet study, effects on low sodium oxybate on sleep stage shifts was also decreased as they got further into deep sleep. So how do we address cardiometabolic risk? Obviously, addressing daytime sleepiness. We need to improve their daytime sleepiness. That's usually the #1 complaint. Most of these patients are coming into us. The therapies we use, we have to be mindful of what that impact might have on that aspect. And then in terms of tools we can use in terms of pharmacotherapy can have that implication or impact and be monitoring that closely. Obviously, non-pharmacologic, it can be challenging to encourage exercise in a patient that's very sleepy. And good sleep hygiene, I think this is often overlooked in this patient population as well. And then scheduling daytime naps, which is not always easy depending on their career or school or whatever situation they're in. Psychosocial support, I think that's a big one. We try to encourage seeing our patients with their family members or someone that's close to them to encourage that this disease is a serious impact on their lives, and then focus on weight loss when possible, and then monitoring their dietary intake.
All right, nice hand for Dr. Roy, please.
Thanks.
For this part of the presentation. Thank you, sir.
Thank you.
Next up, exploring behavioral and mood comorbidities in narcolepsy. Dr. David Plant will be with us here in just a moment.
For those of us who manage these patients with narcolepsy, I think there's a broad appreciation that there's a lot of psychiatric comorbidities that can occur. So this is a nice little Venn diagram, like pointing out that depression is common, anxiety, and even besides ADHD, things like eating disorders and schizophrenia. So we'll kind of walk our way through some of these diagrams. One at a time. The biggest issue is usually depression. For those of you who don't know me, I really like meta-analyses and these types of forest plots. So this is a pooled estimate of how common depression is amongst patients with narcolepsy. So if we look across these 35 plus studies, what you'll see is about 32% of patients with narcolepsy are going to have significant co-occurring depression. Now, there is some variability across studies, but that's a pretty good place to start us off. About 1/3 of our patients are going to have significant depression. When we look at the odds ratios, I know Dr. Roy talked about this. This looks at the meta-analytic data of what the increased odds are of having depression in people with narcolepsy compared to controls, right? So it's a little bit different from prevalence. And what we see is a pooled odds ratio of about 3.5. So to put that in context, that's higher than the odds ratio that's associated with having a first-degree relative who has depression. So this is pretty significant increased odds of having depression if you have narcolepsy. When we think about what these implications mean for high rates of depression in narcolepsy, there's a lot of things that come up. So one is that there can be a lot of challenges clinically because there's a number of overlapping symptoms, especially when we think about various neurovegetative symptoms that can occur with depression. So things like poor concentration, potentially hypersomnolence, etc. Also, sometimes patients, because of the co-occurring psychiatric condition like depression, may do things like avoid certain social situations, or they may be somewhat anhedonic and not go out, and that could be because of depression. It also could be because people are afraid of certain social situations triggering cataplexy, right? So there's a bidirectional relationship that can occur. Sometimes patients with narcolepsy have very frightening or vivid dreams, as Dr. Roy alluded to, and that can be coupled with things like sleep paralysis and hypnagogic and hypnopompic hallucinations. And so that sometimes can actually impact their day and cause negative consequences downstream of that. And then probably the biggest thing is in clinical practice, I think we really have to do a good job of monitoring for depressive symptoms. We can do that through a number of different ways. A lot of self-report scales are available, including things like the PHQ-9, the Zung, and also the Beck Depression Inventory. So besides depression, ADHD is also very common in narcolepsy, and that came up in earlier questions. So again, when we look at meta-analytic data, it's probably fair to say that about 25% of patients with narcolepsy are going to have co-occurring ADHD. So again, there's a lot of variability across studies, but again, 1 in 4 patients with narcolepsy would meet diagnostic criteria for attention deficit hyperactivity disorder. Interestingly, in this particular paper, they did a sub-analysis and looked at rates of ADHD in people who have either NT1, so type 1 narcolepsy, or NT2, type 2 narcolepsy. And interestingly, the NT2 patients seem to have higher rates of ADHD, or at least a higher prevalence of nearly over twofold, so 46% compared to 20%. That was statistically significant in this particular study. So there's, besides depression, besides ADHD, there's obviously other psychiatric comorbidities that come up quite frequently. Patients with narcolepsy tend to have increased anxiety disorders and also increased state and trait anxiety scores. So if we asked people to fill out various questionnaires about that. So anxiety is, again, very common. It's hard clinically to tease apart depression and anxiety quite frequently, to be honest with you. And then also eating disorders. So the EDEQ is an eating disorders survey or questionnaire. When that's been administered to patients with narcolepsy, they have higher scores compared to controls, especially increased night eating behavior and activity. Not necessarily sleep-related eating, but binge eating or eating excessive quantities in the night while awake. It seems like there's an association between being female and also taking antidepressants with increased EDE scores, at least in this survey. And interestingly, there was a negative association between the use of sodium oxybate and disordered eating in this particular study. There are also psychiatric conditions that come up less frequently clinically than depression, ADHD, and anxiety, but certainly can be very important and relevant to treatment. So one being schizophrenia. So schizophrenia being a classical psychotic disorder, in Finland, using data from their large sort of national registries and health system, they basically were able to look at the prevalence of schizophrenia and what the prevalence was specifically in patients with narcolepsy. So it was about 2%, so that sounds relatively low, but you have to keep in mind the prevalence of schizophrenia itself in the general population is about 0.9%, right? So that's an increased risk of having both of these problems at the same time. The study did some Mendelian randomization and genome-wide association studies that suggested there were some causal associations potentially from going from narcolepsy to schizophrenia, and then potentially going back the other way from schizophrenia to narcolepsy. But you have to keep in mind, we don't really know any of these mechanisms, right? But we certainly have seen patients, and do see patients that have both schizophrenia and narcolepsy, and they may co-occur, and they certainly can affect the treatment of one another. And another major psychiatric comorbidity that comes up from time to time in clinical practice is bipolar disorder. So this is a major mental illness characterized by not only periods of depression, but periods of mania or hypomania. There's really not a lot of data, to be honest with you. We see this from time to time clinically, but there's not good prevalence estimates in terms of how common of an issue it really is. So when we think about, again, the effects of psychiatric conditions when we're taking care of patients with narcolepsy, what we do know is that when we look in depth at this, that patients with narcolepsy with a comorbid psychiatric diagnosis are more likely to complain of fatigue, to have more apathy, to have obviously disturbed nighttime sleep as well, and just worse quality sleep in general. And then also having a psychiatric condition and having narcolepsy increases the risk of impairment in a number of different domains, specifically here, so things like ability to make friends, trouble achieving overall potential, and then impacts on intellectual functioning, at least self-perceived intellectual functioning, and obviously, not surprisingly, mood, right? So they have the kind of complex bidirectional relationship. So this has led some folks to hypothesize this idea of a vicious cycle that can occur in patients with narcolepsy, especially in the context of depression. So we start with what we know is at baseline going to be there for every patient with narcolepsy, right? People are going to have excessive daytime sleepiness and complaints of hypersomnolence. That can also bleed into issues with low energy, fatigue, etc. That combination of things can lead to lifestyle changes, decreasing exercise, avoiding socialization, like staying in bed, etc. And then that can lead potentially to a downstream effect of diminished joy of life, right? And then that can disrupt your mood even more and then potentially feed back and cause more sleepiness. So you end up in this vicious cycle for a lot of patients that we have to help them get out of. So I would be remiss as a psychiatrist not to mention that besides these psychiatric conditions, it's important to think about risk of suicide in narcolepsy, which does not occur only in depression. It occurs in other psychiatric conditions, certainly. But this is probably the most important endpoint that in psychiatry we focus on, right? Because it's an issue of significant mortality. So this was a very interesting study that was done in France that looked at basically a very careful evaluation of almost 300 patients with narcolepsy, here in the case NT1. And what they found was that patients who had type 1 narcolepsy had higher rates of suicidal thoughts, right, compared to controls. Risk factors for having suicidal ideation included being male, and I think really importantly, having more severe narcolepsy symptoms, right? So the more severe their narcolepsy was, the more likely they were to have suicidal ideation. And they confirmed this also not just with sort of basic questionnaires, but also a standardized sort of evaluation as well. And what was really important is that with management, it seemed that not only did sort of overall depression rating scales improve, like the Beck Depression Inventory, but also some of those suicidal thoughts decreased as well. So I think it's really important to ask these questions of patients to understand both how their mood is doing and also if they're having any safety concerns or thoughts about hurting themselves or others, because it's important to help these patients if they are in a very dark place. So in terms of how we can, as sleep medicine providers, help identify psychiatric conditions in patients with narcolepsy, we have a lot of tools at our disposal. You can use standardized assessments. I've already alluded to the PHQ-9. If you take away 7 of the questions and just use the first 2, you have the PHQ-2, which asks about depressed mood and anhedonia, and that is actually very effective screening tool for looking at depression. There's also more longer questionnaires like the Inventory of Depressive Symptomatology, which comes in a self-report version, the Beck Depression Inventory. If you so choose, you could also harken back to medical school and think about doing a full mental status exam. So basically that's asking about a number of, or evaluating a whole host of areas in terms of interactions with the patient, their mood, their affect, their thought processes, et cetera. And then even if you don't have time for that in routine clinical practice, I really encourage people to ask questions, again, and don't be afraid to bring up these things. I try to ask all of my patients, how's your mood been? Because that really tells you a lot and gives you the opportunity to ask important follow-up questions about their mental health, which is critically important. So as we manage these patients, it's important to think about how the medications we use to treat narcolepsy also overlap with the treatment of various psychiatric conditions. So this is another nice Venn diagram from a review that was published that really highlights narcolepsy being in the center and a number of the agents that we use in the management of narcolepsy, SSRIs, SNRIs, tricyclics, potentially in the treatment of cataplexy, and then also things like stimulants in the treatment of ADHD have a fair amount of overlap. So again, antidepressants are really key, probably the most prescribed medication in the management of psychiatric conditions, and they are often used in the treatment of narcolepsy. Classically, they're used as anti-cataplectic agents. The pluses of them are they're readily available and easy to get. So they also can help manage some REM intrusion type symptoms, so things like sleep paralysis or hypnagogic or hypnopompic hallucinations. And most people are typically prescribing either SSRIs or SNRIs, largely because they're comfortable with them, they have a relatively ease of prescribing, etc. There are some older agents in the antidepressant class that some of us still use, things like protriptyline, which is a tricyclic antidepressant that is really one of the only ones that is paradoxically alerting. Most of the agents from that class are sedating. And there's also selegiline, which is an old monoamine oxidase inhibitor. That too can be wake promoting. The challenge is, even if you're using it in the patch form, once you get above the starting dose, you have to pay attention to a low tyramine diet, which means avoiding things like delicious cheeses and salamis and beer. That doesn't play very well in my home state of Wisconsin. That said, we do keep it in mind. So then also classical stimulants, right? So these are things that are commonly used in the treatment of narcolepsy, but also attention deficit hyperactivity disorder. So it's really those are the mainstays of treatment. Also atomoxetine, which is a specific norepinephrine reuptake inhibitor that's FDA approved to treat attention deficit hyperactivity disorder, may also have some modest anti-cataplectic effects, and then also can have a mild wake promotion effect. So I will use that in my clinical repertoire as well. Agents that we tend to try to avoid when we're managing, if we choose to manage psychiatric comorbidities, really we want to avoid sedating agents, which I think is common sense, right? These are patients who have excessive daytime sleepiness, so piling on with medications that make them feel sleepy wouldn't be a great strategy. So sedating tricyclic antidepressants should probably be avoided. Mirtazapine, which is a very sedating antidepressant. It should also be avoided, generally speaking. At times, although we don't typically use antipsychotics to manage, certainly we don't use it to treat narcolepsy, but people may have either a refractory mood disorder that requires treatment or a co-occurring psychotic disorder like schizophrenia, like we talked about. So when if we're forced to use or need to use an antipsychotic medication, really the ones that we would tend to lean towards are things like risperidone, ziprasidone, and aripiprazole, not because they're not sedating, but they're less sedating than some of the other agents in this class, which are very sedating. And then also if we're needing to pick a mood stabilizer to manage someone's bipolar disorder, classically lamotrigine is going to be the agent that's going to be the least sedating from that class. And just as a reminder, sometimes patients with narcolepsy have disturbed nighttime sleep. They may complain of that. It's not a good idea, and it's actually very contraindicated to use a DORA, a dual orexin receptor antagonist, especially in patients with NT1. So please do not do that. And I'll conclude with this particular slide that's a very interesting study that looked at reports of treatment emergent adverse events across these different agents, so they're captured from the literature over time. And this breaks down a lot of the different medications that are used to treat narcolepsy. Now it's complicated because you can see there's a huge difference in the number of responses, right? So sodium oxybate has over 10,000 responses, whereas agents like modafinil, there's only 169. So it's a little bit difficult, but there's a couple of important sort of take-home points. The first is that depressed mood could occur across all of these agents. Now the thing that you have to wonder about is this because of the medication itself, or is it because these folks tend to have more or higher risk of depression, right? So they may just have it. It may not be related to the agent at all. The other thing to keep in mind is that there is the potential for suicidality or suicidal ideation that may come up across all these agents, but is more commonly reported as an issue in sodium fetrol and sodium oxybate. But again, you have to take all of these data with a grain of salt, right? Because again, higher rates of depression, higher rates of suicidality in the disease itself. So the main take-home point is these data are interesting, but we as clinicians have to ask the right questions and manage our patients accordingly. So with that, I'll hand it off.
Nice round of applause for Dr. Plant, please, and the presentation. By the way, I just thought I would tell you that the beer and cheese thing is not just endemic to Wisconsin.
That's fair.
It would not go over well in a lot of places. But that's okay. Our next segment, weighing the evidence in the selection of narcolepsy therapeutics, the right medication at the right time. Dr. Michael Thorpe will present that in just a moment.
Let's talk about treatment. And first of all, of course, the goals of treatment. The prime aim is to reduce daytime sleepiness. Sleepiness is obviously the most severe and the most difficult symptom to treat in narcolepsy. So that's our prime focus. We want to control the abnormal REM phenomena. And it's not just cataplexy, but of course, if a patient does have cataplexy and severe cataplexy particularly, we certainly want to suppress that and completely stop it. But there are other REM phenomena that are important as well. And I've certainly seen patients where the dream content in a NT1 patient has been the most important thing in that patient's life, even more important than the daytime sleepiness. So the other abnormal REM phenomena need to be treated. And whether it's dream content, the hallucinations, or the sleep paralysis, it's important. Disturbed nocturnal sleep, not usually the most predominant symptom in patients with narcolepsy, but certainly an associated symptom that needs to be treated. And we want to improve their patients' cognition, psychosocial, and work functioning. And make sure that they're safe, and safe not only safe themselves, but also that they're not a danger to the public. We don't want these patients falling asleep driving, for example. And with medications, we've got to make sure that we have an acceptable risk-benefit ratio and consider the adverse effect of medications, and we're going to talk a lot more about that as I go through this. This is just some data looking at challenges associated with narcolepsy, and it was on a couple of hundred patients with narcolepsy, and 250 physicians were asked to consider these aspects and these challenges. One is here, the first one, narcolepsy is a life-changing disorder for people, and you can see majority of patients and physicians felt that was extremely an important element. Living with narcolepsy being a daily struggle, people with narcolepsy having difficulty living a normal life, hard to be a parent when you have narcolepsy, hard to be married or in a relationship. And so not only are the overall figures here high, that patients with narcolepsy have these problems, but I think of particular interest is here is that you're seeing that the physicians are rating it a little higher in their patients than the patients are. And I think what that sort of should tell us is that patients have lived with these things for many years, and I think they tend to underestimate the impact of it. And I think if you don't have narcolepsy and you're looking at a narcolepsy patient, and this goes for family members as well as for physicians, you see them in a slightly different light than the patient sees themselves. So just remember that many patients will tend to underestimate the severity of their problems when it comes to narcolepsy. This is some data from a Crescendo study. This is a survey that was done not just fairly recently. And what it looked at is patients that were currently on treatment. So our current patients that are being treated to the best of our knowledge with current medications, and what they considered was still problems. As you can see, 91% of patients, even though with current modern day treatment for narcolepsy, still consider daytime sleepiness as being a concern. And even those that have cataplexy still may get some breakthrough cataplexy and have occasional episodes or have situations where they have to try to prevent the precipitation of cataplexy. So you can see there, despite our current medications, there are still major problems in patients with narcolepsy. This is looking at comorbidities in narcolepsy, and you've seen a lot of data on this from both David and from Asim. And you can see the mental disorders, particularly depression and anxiety, rank very high in these patients. But sleep apnea occurs, and that certainly is going to influence treatment. And so all of these comorbidities is going to play a part when it comes to considering treatment in narcoleptic patients. So again, the cardiovascular issues, and you saw the slide, Asim showed this, and I just want to emphasize that we have to consider the potential and the risk of patients from the cardiovascular point of view when we're selecting medications. And the cause of the cardiovascular issues in patients, and Asim went through this very well, talking about the different factors. I just want to highlight the importance here of narcolepsy medications. And we don't want to make the cardiovascular problems worse in our patients because of our treatment that we're going to give them. When we're thinking about medications for the treatment of narcolepsy, of course, we have a large number of medications that are available to us. I just want to show you the sort of time course. This is evolving the whole time, and so it's extremely important to keep up with this because at the far right-hand side of the slide, you're going to see a lot more items coming up over the next few years. But it all really started back in the 1950s, as you can see, with methylphenidate. Been around for a long time. And then the amphetamines were introduced and approved for narcolepsy. So those traditional stimulants have been around for a very long time and still widely used. Personally, I'm not a great fan of that for most patients with narcolepsy. I think because of the newer drugs that we have, they're much more effective and also have less side effects. Then you can see that we had modafinil came along after the amphetamine and methylphenidate. And then we had oxybates, initially regular sodium oxybate. Then we had another form of modafinil, armodafinil, a longer acting form. Then pitolisant and solriamfetol became available. Then the next drug approved was low sodium oxybate. And then finally, the once nightly sodium oxybate has been approved. And so it's the most recent new drug to be approved by the FDA for the treatment of narcolepsy. But as I say, we're likely to see major changes in terms of medications in the near future. So when we think about the treatment of patients with narcolepsy and medications, we really need to think about their mechanism of action. And as you can see from this slide, there are lots of different mechanisms of action. And because for the majority of patients with narcolepsy, they have polypharmacy. They're going to have more than one drug. And so we often will combine medications that have different mechanisms of action, not just the same mechanism of action. You can see here, caffeine affects adenosine receptors. Not many patients with narcolepsy like to use caffeine. They find that it causes a whole body stimulation that's rather unpleasant. And in my experience, most patients with narcolepsy have given up taking caffeine. And then we have the methylphenidate and amphetamine, traditional stimulants. They're sympathomimetic. They affect virtually all the alerting neurotransmitters in the central nervous system. We have the modafinils, which are primarily dopamine reuptake inhibitors. They also have some other effects. And then oxybate works by a very different mechanism, of course, GABA B agonist. Solriamfetol, dopamine norepinephrine reuptake inhibitor, primarily alerting, not for cataplexy. And then we have the histaminergic medications, the H3 receptor antagonists, inverse agonists that increase brain histamine. Pitolisant we have available. Similisant still under investigation. It's just completed phase 3 studies, and there's a potential that it could be approved in the not too distant future. Whether it holds any advantages over pitolisant, we're yet to see. Then there's reboxetine. I'm going to talk a bit about reboxetine. That's also just completed phase 3 studies. It's a selective norepinephrine reuptake inhibitor. It's the first of the antidepressant class of medications that has undergone detailed evaluation in the treatment of narcolepsy. And I'm sure you'll be hearing much more about that in the near future. And then, of course, the future lies really with the orexin agonists, and I'm going to talk a little bit more about the different types of orexin agonists under investigation, but the TAC-861 is certainly the one that is leading the field at this point in terms of the studies, and phase 2 studies just having been reported in the New England Journal of Medicine. Mesindol is another drug that's under investigation, said to be a partial orexin agonist as well as having some other sympathomimetic type activities. Okay, the main drugs that we use, certainly oxybate is proven to be the most widely used medication, and the reason for this is because it's the only drug that treats all the features of narcolepsy. So it improves nocturnal sleep, can really be extremely effective for cataplexy, reduces other abnormal REM sleep phenomena such as the dream mentation, sleep paralysis, the hallucinations. And so and there's some evidence that maybe even independent of its effect on sleepiness, that it may improve cognitive function, although that's yet to be proven. And it is approved now, oxybate, for children. Patients 7 years of age and up can now use oxybate. So very effective medication that's approved across all age groups. There's the mixed salts oxybate that I mentioned. The advantage of this is that it has a low sodium content compared with regular sodium oxybate. It's a mix, as you can see, of various cations, calcium, magnesium, potassium, and some sodium oxybate. And this is an alternative to the earlier use of sodium oxybate, which has been around since 2002. And then we have once nightly oxybate, and this, as it's stated, it's just given once at night before bedtime. And you can see the PK curves here. You can see the difference between twice nightly oxybate, which is either sodium oxybate or low sodium oxybate. You can see that dual peaks that occur with the twice nightly oxybate, and the more smoother effect over the night of the once nightly oxybate. There is some data being presented at this meeting talking about sodium oxybate as compared with non-sodium oxybate, and there is evidence to suggest that switching from a sodium oxybate to a low sodium oxybate actually shows some benefits in terms of cardiovascular parameters, in particular in terms of heart rate and blood pressure. The oxybates are really the first-line treatment for the treatment of narcolepsy, and we have this choice between split dosing, using one dose, or using 2 doses, or even sometimes 3 doses. And very rarely, some patients have even used 4 doses in a night, 2-hourly intervals, but that's pretty unusual. But typically, these drugs are either used once or twice in a night. And the side effect profiles are interesting with these medications. A little bit different to a lot of medications is that sometimes some of the side effects can be improved by increasing the dose of oxybates. Particularly if patients take a dose, for example, at the beginning of the night, they don't fall asleep quickly with it. Not all patients fall asleep immediately when they take oxybate at night. Some patients have quite a lot of difficulty despite oxybate at night. And then they have drug on board and they can get some confusion and they get some adverse effects associated with feeling of the medication. And very often that can be improved just by increasing that first dose to get them into sleep quicker, for example. Other patients, depending upon the symptoms, you may need to reduce the dose. Okay, just to go through some of the other medications that are currently available before we get on to the medications that are potentially going to become available to us. We have the modafinils, regular modafinils, now been around for quite a long time, and it's a medication which is alerting, does not have any benefit, particularly on cataplexy at all. The thing about the modafinils, one of the main problems I find with the modafinils is that they tend to affect ethinyl estradiol. And as 50% of our patients are female, and because narcolepsy, median age of onset of narcolepsy is 16 years, so many of our patients are in the childbearing age group and are on oral contraceptives. And so that can be a problem with modafinil and the longer acting form of modafinil. But in general, they're quite well tolerated and can be quite effective, but some of the newer agents may be even more effective. The amphetamines and methylphenidates I mentioned have been around for such a long time, and I think that they're gradually being phased out. There is this data from the Mayo Clinic where they looked at patients with type 1 narcolepsy who were taking these medications and found that their doses gradually increased, and they looked at those who were using more than 120% of the recommended maximal dose, and they found higher rates of psychosis, psychiatric hospitalizations, tachyarrhythmias, polysubstance abuse, etc. And there can be significant side effects associated with the traditional stimulants, and an article not so long ago showed new onset psychosis in patients who were on therapeutic amphetamines. And there can be deaths. In 2014, there were 1,000 deaths with prescription, not with illegally obtained, but rather with prescription stimulant medications. Solriamfetol, one of the newer medications, dopamine norepinephrine reuptake inhibitor. It's approved for treatment of daytime sleepiness, not only in narcolepsy, but also in sleep apnea, at slightly lower dose, starting dose in sleep apnea than in narcolepsy. But it's effective. The advantage of solriamfetol is it's not metabolized in the liver. It's renally excreted, so it's not going to interfere with medications that are going to be metabolized in the liver, and has that advantage. Like all of the alerting medications, it can cause some mild changes with regards to blood pressure and heart rate, and also can be central nervous system stimulation, and as with all the alerting agents, so that has the potential for exacerbating anxiety disorders, for example. But that advantage of not affecting ethinyl estradiol and therefore not affecting oral contraceptives is a big plus with solriamfetol over the modafinils. Tolosint, so this is a histamine receptor inverse agonist antagonist, as mentioned. An effective agent for both cataplexy and sleepiness, treats both symptoms. Major concern is with regards to potential for QTc interval impairment. It is metabolized in the liver, so like the modafinils, can affect ethinyl estradiol, and so will affect the efficacy of oral contraceptive agents, but has the advantage of being non-scheduled medication, and so it's not a controlled medication, so it's easy to prescribe, and for physicians who like to prescribe patients a year's supply of medication, you can do that with pitolisant. But it's approved in children, like the oxybates. In fact, for pitolisant, it's actually 6 years and up, whereas with the oxybates, it's 7 years and up. But it is another and newer agent that's approved for treating childhood narcolepsy. Antidepressants, they can be effective for treating cataplexy, not so much for daytime sleepiness. Potential's there for quite a lot of adverse effects in terms of sexual side effects. They can be disturbing for nocturnal sleep. One of the most widely used ones, venlafaxine, and the norepinephrine reuptake inhibitor, which is very effective for cataplexy, but it can exacerbate nocturnal sleep and actually precipitates REM sleep behavior disorder and other abnormal REM phenomena at night, but very effective for treating cataplexy. But with all of the antidepressants, if they are stopped suddenly, there is that potential for patients developing status cataplecticus. So that's a particular concern in the type 1 narcolepsy patients who have severe cataplexy. At the current time, there aren't any of the antidepressants FDA approved for the treatment of narcolepsy, even though they've been used for many years and are still widely used, but they're all used off-label. Now, reboxetine, I mentioned, is an antidepressant that's just undergone phase 3 studies. And interestingly enough, this medication was shown to be effective for cataplexy. It was the primary endpoint in these studies, but it's also shown to be effective in treating other symptoms of narcolepsy, such as the sleepiness and impaired cognitive function. And there's a potential that in the not too distant future, we may have our first FDA-approved antidepressant medication, norepinephrine medication, and cortical dopamine modulator approved. Okay, so what about the orexin agonists? This is a partial list of those orexin agonists that are out there. But these ones have really started to get some data. There are a lot of other ones that we don't have any data on them yet, but undergoing preclinical evaluation. But 2680 in phase 2 studies for NT1, NT2, and IH. This ORX750, that's also just starting in studies for NT1, NT2, and IH. This E2086, it's in phase 1 studies for type 1 narcolepsy. This BP115205, which is just in preclinical evaluation. And then MK65552, which is in phase 1 studies for type 1. And then there's the TAC861 that I mentioned, has actually completed phase 2 and is starting on phase 3 studies in NT1. So why are the orexin agonists of such interest? It really stems from this data with TAC925. This is an intravenous form of an orexin agonist, not available orally. But the first studies were done, and this is really the first data that came out that made people very excited about the orexin agonist. And you can see it was given intravenously daily over a period of 7 days. Now, if you look at this, is in the patients with type 1 narcolepsy, and this is looking at the mean sleep latency on the maintenance of wakefulness test. And what you can see is the baseline, how these patients were severely sleepy on their baseline, and then they were given this medication. You can see the doses there of 11 milligrams and 44 milligrams of this particular orexin agonist. At the highest dose of 44 milligrams, you can see in red that these patients were almost hypervigilant. Their MWT is 40 minutes. That means they didn't fall asleep at all on the maintenance of wakefulness test, right at the beginning of the study as well as towards the end of the study. With the lower doses, there tend to be some wearing off of effect as the study went on, as you can see in blue. But certainly at the highest dose, shown to be very effective. Now, they also gave it to patients with NT2. And the thing to look at here is look at the doses. The lower dose was 44 milligrams, the high dose was 112 milligrams. And you can see variable effect, but still on the MWT and some of the naps on the MWT, these patients just didn't fall asleep. Very alerting, but not as alerting as found in the NT1 patients. And so these results have been reflective of all the studies that have been done since that, in that what we find is that the orexin agonist is extremely effective in improving alertness and also for cataplexy as well, but to the point that you may even go to overstimulate some of these patients, and that you need higher doses in the type 2 narcolepsy. One of the suggested reasons for this is that maybe the receptors in the type 1 patients are hypersensitive because they have lost orexin and they're not getting stimulated by orexin. They are more sensitive, and whether over time there's going to be wearing off of effect, we don't have good data to look at that as yet, but we don't know. Maybe the sensitivity will go down in the NT1, but certainly NT2 patients are probably using higher doses, which raises the potential for increased side effects. So this is the data that was just published in the New England Journal with regards to NT1. They used low doses. That had some problems, and I'll show you in a minute, with regards to adverse effects with other orexin agonists. So they used pretty low doses, 2 milligrams or 0.5 milligrams twice in a day, 3 hours apart for the second dose, 2 milligrams twice, and then 2 milligrams and 5 milligrams. So 2 milligrams at the beginning, 5 milligrams 3 hours later, and then a single dose of 7 milligrams. What they found was the most effective one, and if you can read this data, is that was the 2 milligrams and followed by the 5 milligrams. So the dual dosing produced the greatest improvement in the maintenance of wakefulness test. But look at the numbers that we're looking at here, and so the mean change in the maintenance of wakefulness, 25.2 at the maximum dose effect. So not as much as we saw in that TAC925 study. So they're not making patients hypervigilant, but they're getting a significant improvement, even if they're not completely eliminating daytime sleepiness. Adverse effects, as you can see, 77.8%, but none of them led to any discontinuation of the medication. And urinary frequency, urgency, turned to be a significant side effect, as was sleep disturbance, insomnia. This is so the big concern really with these medications is finding their appropriate dosing. Is it once a day, twice a day, smaller dose at the beginning of the day, higher dose in the middle of the day, or vice versa? So that all that needs to be sorted out. So there's the dosing, and then there's the adverse effect profile. And so with the alchemy studies, you can see there was insomnia, polyuria, salivary hypersecretion, appetite effect, dizziness, nausea. They found this at the maximum dose that they were using, which in their study was 8 milligrams. But other of these orexin agonists have had somewhat similar sort of side effects. The TAC 994 was hoping to proceed into phase 2 or 3 studies, but fortunately patients developed so that had to be stopped and is no longer being studied. The orexin 750, not a lot of data because mainly the only data we have is in sleep-deprived people, not narcoleptics, but they didn't have any major side effects in their studies, and they used relatively low doses in their studies. And then there's JZP 441, and they were testing that in NT1, and they stopped it because of, they said, visual disturbances and cardiovascular effects. I assume the cardiovascular effects were the main reason for that study being stopped. Okay, so when it comes to treating patients, we need to have an individualized approach. We need to consider the current medications, the risk of cardiovascular disease, lifestyle, potential for abuse, misuse of medication, drug interactions, the various dosing regimens that we're using, and of course patients' tolerability. Patients, as I mentioned earlier, often require multiple medications. I would say the majority of patients with narcolepsy are on at least 2 medications, many patients on 3 medications, and so there's always that potential for interaction. And of course, because of what you've heard so far today, the large number of comorbidities, psychiatric, cardiovascular, and other comorbidities, they need to be considered as well. And clinicians need to be able to really talk to their patients about their overall health issues, the goals of treatment, and they need to have this clear decision-making interaction with patients to get a plan that's going to work for the patient, that's not going to exacerbate any underlying disorder. So when we're talking about the cardiovascular issues that we need to be concerned about, obviously amphetamines being sympathomimetic will increase heart rate, blood pressure, and same with the modafinils, armodafinil and regular modafinil, methylphenidate. These all have cardiovascular stimulatory effects, and so we need to be concerned about that in any of our patients. The oxybates, of course, we have low sodium oxybate, but we have high sodium oxybate. So in some patients, we need to be concerned about that sodium load that may be exacerbating any underlying cardiovascular problem. It has the potential for causing QTc interval prolongation that may worsen in patients who already have some tendency for QT prolongation, but if it's combined with other drugs that have that potential, then that could be fairly disastrous for some patients. So we need to be careful with pitolisant. Solriamfetol, like the other alerting medications, tends to increase heart rate and blood pressure. Treatment considerations, there are certain groups that we might want to avoid using high sodium oxybate formulations, those with cardiovascular disease, particularly hypertension, heart failure. Sedative medications, of course, will interact with sodium, with oxybate. Shouldn't be taken with alcohol, so it's a lifestyle consideration we need to consider. With the modafinil, armodafinil, and pitolisant, you may want to avoid that because they're metabolized in the liver with patients with severe hepatic disease or on oral contraceptives. The traditional stimulants, again, patients with cardiovascular disease, anxiety disorder. Pitolisant, concerned about arrhythmias, as I've mentioned. The sodium load and solriamfetol, because solriamfetol is excreted in the kidneys, that if patients have renal disease, you need to take that into consideration. Oxybates in patients with depressive disorder may exacerbate that. And as you have already heard from David, that there's a potential for suicidal ideation in these patients, and we certainly don't want to worsen that or have them excessively use a strong sedating agent like oxybate in a suicidal attempt. And then there's psychosis, as David also mentioned, can occur in these patients. So any of the alerting agents may tend to exacerbate that. So in conclusion, there are many estimates on the prevalence of narcolepsy. We really don't have a good number on it. Asim mentioned the figure of 1 in 2,000 of the population, which approximately means 200,000, maybe 200,000 is an upper limit. This from a paper by Morris Ohayon found 126, estimated 126,000 patients. So somewhere between 126,000 patients with narcolepsy and 200,000 patients in this country. And so beside the main symptoms of narcolepsy, we have to consider the comorbidities, in particular the psychiatric comorbidities, metabolic comorbidities, and the cardiovascular disorders. And so it's most important that we really talk to our patients and evaluate these other conditions that they might have, their particular concerns about treatment, and really doing our best to try to minimize the exacerbation of any of these underlying comorbidities in our patients.
Dr. Thorpe, thank you very much.
It. Thank you.
Ladies and gentlemen, give yourself a nice round of applause. Gentlemen, thank you very much, and I thank you all very much. Have a wonderful rest of the weekend. I'm Ed Berliner. Thank you.